Delivering home oxygen safely to patients is a concern for installers, gas suppliers, fire services, and regulators alike. Oxygen service providers have been educating patients about the risk of fire for decades. Despite their best efforts, though, home oxygen fires remain a material and persistent public health issue. In the U.S. alone, it is estimated that between 100 and 150 patients die every year from fires involving home oxygen. A further 1,200 are treated in hospitals for burns. Meanwhile, around a third of fires result in a cylinder explosion, posing a serious risk to third parties, including family members, neighbors, and firefighters. The statistics are shocking, especially when you compare them with figures from other countries. In fact, studies have found that an American home oxygen patient is many times more likely to die in a home oxygen fire than elsewhere in the world. The good news is that with the right measures, the devastation to lives and the damage to property caused by home oxygen fires can be tackled. Most COPD patients have the condition because they have smoked cigarettes for a considerable time. The addictive nature of nicotine means that it is perhaps unsurprising that up to 50% of home oxygen users continue to smoke. That means that there are currently at least 450,000 home oxygen users in the United States who could be regularly putting themselves and others at risk by smoking. Patient education and warnings from home oxygen providers about the risk of fire undoubtedly have some effect. But based on the number of home oxygen fire deaths and injuries that still occur around half a century after home oxygen was first provided, it's clear that education alone has not and will not solve this problem. So, how do home oxygen fires start? And exactly how does the lit end of a cigarette result in a flash fire that causes such devastation? We asked our research team to develop experiments to understand the mechanism and find out. This is what they found.
The outside of a cigarette can burst into flames in an oxygen-elevated atmosphere. The burning cigarette vaporizes the underside of the nasal cannula, releasing more fuel to mix with the oxygen. This can ignite the nasal cannula or the oxygen tubing, and the resulting fire tracks back to the oxygen source. At around 1 meter per minute, this releases toxic hydrogen chloride gas.
How high do the oxygen concentration levels need to be to pose a risk?
Our studies show that a lit cigarette in an oxygen concentration of around 50% will completely ignite. When the smoker inhales, ignition occurs in oxygen concentrations of just 40%.
How does this relate to a patient? And what are the oxygen concentration levels around the nose of an oxygen user?
We took oxygen concentration measurements at different oxygen therapy flow rates, and this is what we found. This is what happens when a cigarette burns at an oxygen flow rate of up to 1 litre per minute. A flow rate as low as 1 litre per minute is enough to create the conditions needed for a cigarette to ignite. Nearly all oxygen patients require 2 or 4 litres per minute. The conditions created when a patient smokes while using oxygen mean that it's almost inevitable that a fire will start, probably when they inhale. It's also worth remembering that the levels of sebum or skin oil, facial hair, and the presence of certain emollients may exacerbate the problem.
How quickly does this happen? And why don't patients react and pull the nasal cannula away?
We ignited cigarettes at lots of different oxygen therapy flow rates. We found that it all happened so quickly, nobody could react to that.
This is what happens.
Some patients take the nasal cannula off and place it in the lap. They know that they shouldn't smoke while they're using oxygen, but when they do, they unwittingly create conditions for an oxygen fire. Even with a small amount of smouldering ash, this can ignite if the oxygen concentration is elevated, and this can lead to a flash fire. To summarise, most patients use oxygen at flow rates between 2 and 4 litres per minute. If they smoke while using it, a flash fire is almost inevitable.
What is the scale of the problem? Consolidated data is hard to obtain. In some cases, patients are reluctant to report fires and fear their oxygen will be removed. Meanwhile, fire service and FDA medical device reporting does not pick up every incident. However, a new study on the prevalence and impact of home oxygen fires in the U.S. has given us the most accurate data on the issue to date. By identifying incidents over a 20-month period from online news reports, the study identified 311 incidents, resulting in 164 deaths, 71 injuries, and 119 minor injuries. This equates to a death rate of 100 home oxygen patients a year in the U.S. Even this is an underestimate, though. For example, the media will not report every incident, and if it did, it may not be reported online and picked up by search engines. Even 100 deaths a year is much higher than previous estimates, though. That rate is equivalent to 6.6 deaths per 100,000 home oxygen patients. Unfortunately, this does not compare favorably with other countries. In Japan, the figure is 3.3 per 100,000. In England, it's just 0.34. That means a home oxygen patient in the States is almost 20 times more likely to die in a fire than a patient in England. Why is there such a big difference in the safety figures? In short, the UK's success is a result of a concerted effort by the UK Department of Health that started in 2006 as part of a broader reorganization of home oxygen delivery across the UK. The department created a multidisciplinary committee to address safety issues, including home oxygen fires, which were prevalent at the time. Now, the results of that work are clear from the incident statistics, which show a dramatic reduction in deaths. So, what are the main characteristics of the UK experience? Firstly, there is a universal contract between the Department of Health and the service provider that requires certain levels of safety and the routine reporting of incidents. Secondly, stakeholders work together.
We feel as clinicians the patients are a high risk, so we do a risk assessment tool. We actually directly refer the patients to the fire service. They go out and do home safety checks with the patients. All of our patients that are on oxygen have to have 2 working smoke alarms within their property.
This means that every patient is protected by working smoke alarms. The U.S. National Fire Protection Association reports that victims of household fires are 54% more likely to survive if a working smoke alarm is fitted.
The suppliers also are doing more regular risk assessments. So they do risk assessments when they install the oxygen and make sure the patient and relatives have signed to say they've gone through those risk assessments, and then every 6 months they have responsibility also to go in and check to see whether there's anything new that's flagged up that's going to be a concern.
Finally, Firebreaks, also known as thermal fuses, are required to be fitted in all oxygen patient circuits. Firebreaks are fitted by the home oxygen provider's service engineer as close to the patient as possible and close to the oxygen source. In the event of a fire, the thermal fuse breaks, triggering a simple mechanism that stops the oxygen flow and preventing it from fueling the fire. This can limit injuries and prevent patient deaths. Some of these measures require new structures to be put in place and may be challenging to implement. Checking and fitting smoke alarms, though, as well as the fitting of fire breaks, are both relatively low-cost, easy steps to implement. Home oxygen fires continue to take the lives of over 100 patients and third parties every year and result in many more disfiguring and life-changing injuries. But as the UK experience shows, with the right measures and a determination to bring about change, this significant public health issue can be addressed. In fact, if similar safety measures were adopted in the US, the number of home oxygen fire deaths would not be 100 or 150. It could be as low as 5.